record. It's exclusively for your use. It's not to be distributed or sent to anyone, and least of all, to be put on social media and other things. These things, I think we need to make them clear from the beginning, and I'd be happy to discuss with you further at the end of the talk.
I have one question, just short.
Yes.
Are we going to receive the presentations, like the courses and the LPs?
Yes, we will send you the slides with the presentations. Basically, you will receive them. Again, this is to be asked to each of the lecturers. They may choose to exclude a few slides if they have a copyright on them or would like to keep them more privately. But basically, you will have them. Okay, so this one is not something about curriculum or about anything that we will ask you at the exam. You don't need to, I mean, it's just an opening lecture to tell you about some things, also some philosophical things, about how we see medicine, about the role of the physician in the modern era, and the journey that started centuries ago with the stethoscope and the place where we are right now. The very fact that we do this from a distance is something that was not possible not long ago. So this is something that I have talked about recently in our National Congress, and Costin Karp was our esteemed professor of cardiology here at this institution, and he was actually the first director of the institution. And here you have on this slide a number of esteemed leaders of cardiology in Romania. This is Professor Karp, to whom I had the honor to work with when I was a young resident. And he was a great clinician, very wise person with great clinical skills. And this is Professor Apetrei, who was the one that introduced echocardiography in Romania many years ago, and who is still active. And this is Professor Gingina, who was until recently the head of our clinic. And so it's always nice to think about the predecessors and the way they helped us evolve to where we are today. So basically, I think it's important because you are starting a clinical rotation. And this is maybe one of the most important. It is certainly the longest one. It's 9 weeks, basically, all in all, cardiology. And I think the main scope is to teach you reasoning skills and the way of clinical judgment. Information you can get from anywhere. You can receive information you can find on Google. In 2020, the access to information is no longer any problem. The problem is how you use it and how you think about the information you can get. And this is what we need to do with our patients, okay? So the way it always starts with history taking, talking to the patient. And this is extremely important. First of all, because in many cases, the full diagnosis is only based on history taking. For example, angina, which is quite common, okay? Angina is a diagnosis that can only be made by history taking. It does not depend on any test, on any machine, on any infrastructure. Just talking to the patient, you see that the patient has angina. This is one thing, medical report. The other crucial thing about history taking is the human relationship you need to establish with your patient. This is the essence of medicine, and it cannot be replaced. Again, I'm saying about any machines or computers or whatever. Computers are great. Artificial intelligence will play a greater role in the near future, but it cannot replace this human interrelation between the physician and the patient. And this is crucial. Thirdly, remember, we talk about chronic conditions. Cardiology is most often dealing with chronic problems. So the patient has a disease and he has to live with the disease for his entire life most of the time. He has to take drugs very often, every day until the end of his life. All of this needs a very good compliance. So the patient needs to understand and to trust you that what you are recommending him is what is really helpful for him. Because if it doesn't, he will not take the drugs and you will not be able to help him. So history is crucial. Once you took the history, then you move on with the physical exam. You examine the patient, you make the percussion, palpation, auscultation, and this brings more information, adding on the information that you have elicited by history taking. And after history taking and physical exam, you reach a clinical diagnosis. A clinical diagnosis which is a workhorse. So I believe this patient has this, and then to move forward and to clarify whether my clinical diagnosis is correct, whether it is complete or I need to make further tests. The way I move forward is that based on the clinical diagnosis, I select a number of tests in order to clarify what the final diagnosis will be. Basically, the way we do it is you talk to the patient, you make the physical exam, and once you've done this, you have in mind a few possible diagnoses, which we call obviously differential diagnosis. Is this? Is it A? Is it B? Is it C? Well, to sort it out, you order some tests, and these tests will rule out some of these possible diagnoses and will lead you to the final correct one. You achieve the final diagnosis. And once you've achieved the final diagnosis, obviously you have some management options. And those management options you need to share with your patient. You need to explain, I believe you have this disease and this poses the following problems, and we have the following therapeutic options. And for each of these options, there are pros and cons. If you choose this, you have some advantages, but you may also have some disadvantages. If you choose the other option, it's also pros and cons. And you share this information with your patient, and the treatment is, in the end, basically decided by the patient who is following your recommendations. So it's not something that we are coming and telling the patient from above, you should do X, Y, and Z because that's what I'm telling you. The patient is in the center of his own treatment because it's about himself and his life. You need to remember this. This is extremely important. And then once we've agreed together on a specific treatment scheme, we also discuss how to follow the patient, how often he will come back, what will be done on those follow-up visits, and so on. This is also something that needs to be individualized. So this is a slide trying to summarize the whole journey from when you enter the room of your patient and until, your patient gets treated and how he will be followed during the course of his disease. So basically, this is another way to put it more graphically. You start from the patient's story, you do the physical exam, you use and interpret some added diagnostic information, and then using your rationality and reasoning, you get to a plan, you share the information with your patient for a shared decision making. And also, I didn't tell you, it's not only about the patient, sometimes it's about the family of the patient, it's about the loved ones. But again, the patient will decide in this endeavor. And basically, this is what leads to the whole clinical reasoning spectrum that we start with the history and we finalize with the treatment options. So you need to consider the patient as a whole, collect the information, process it, identify the problems, establish the goals, take some actions, and then, of course, look at the outcomes and reflect on the whole process. And from every patient, you learn something. You learn, maybe I made a mistake, maybe the other option could have been better. And you need to have this feedback because this will help you improve the care of your further patients. And this also comes with experience. Sometimes you can do it by yourself. Sometimes a more senior colleague can provide you some important lessons from his own experience. So basically, if we are to summarize all of that, there is no substitute for sound clinical judgment. And this is something we need to teach you and you need to learn. And unfortunately, a lot of that cannot be taught properly simply online. You need to see patients in the hospital, at the bedside, to talk to them, to realize, the way they judge themselves. This is something that is very difficult to be replaced by any sort of modern distal learning. We try our best and we have means to help, but it's very difficult for every practical step. So now I'm going to show you a few examples of the way that we use clinical exams and the accuracy of it. Basically, you know that nowadays, for every new test, in order to get it on practice, you need some very clear information about the accuracy it provides. Why should I run a test in a patient of mine if I know the accuracy or the quality of information it provides me is really low? I shouldn't, right? But in order to make this judgment, I need some information. I need some numbers. If I'm going to tell you, take this stethoscope, listen to the patient, and what is the accuracy of your auscultatory findings? This is an important question because in the clinical reasoning that I told you about, we will choose a test over another provided it is accurate enough, it is harmless if possible, it is well tolerated, it is painless, and so on. So you have a number of reasons to select the test, but accuracy is among the most important of all, because otherwise, why should I bother? So the question is, what is the accuracy of the clinical exam? and if there are ways to improve it. And this is a randomized trial published many years ago in the American Journal of Medicine. And the authors just took 56 interns rotating on a 4-week cardiology inpatient rotation and have randomized them to receive either a physical diagnostic course by teaching in 8 sessions, or the other group was no supplemental teaching of this sort. So a teaching group and the control group. And before this and after this, they were evaluated on a simulator on the accuracy of their diagnosis on 3 valvular diseases: mitral regurgitation, mitral stenosis, and aortic regurgitation. And to test their skills, they were asked to fill a sort of a form by saying, this patient has this type of a systolic murmur or has this type of a diastolic murmur. So you were taught to listen to the simulator, and then you were asked to provide your diagnosis quite detailed in this sort of way, not only to say the patient has a systolic murmur, but you see here, you have quite a number of possible systolic murmurs, and you are asked to pick one of them, and so on and so forth. So quite a good methodological design. You can see here the accuracy in detecting cardiac disease on this simulator. What you can see here, first of all, the numbers are really low, okay? So you can see here, first of all, the numbers are low. And secondly, you see that although there was some improvement after the intervention, this was not significant and was not different from the group that did not have a teaching intervention. So one conclusion was that the interns had difficulty in identifying 3 types of valvular heart disease before and after an EduCal intervention, and they conclude that our intervention was either of insufficient intensity or insufficient duration to improve the diagnostic skills of these interns significantly. So the point here is that this cannot be taught overnight. You come, you listen, and then you know everything. It's something that you need some exposure to, you need teaching, and you need some time to learn it. Also, this is not only a problem of a beginner, like an intern is coming and he doesn't know much, so you may say, well, lack of experience. Let me show you another study, and this time you can see here 2 cardiologists, 2 established cardiologists, 1 intern medicine physician, 3 senior and 2 junior postgraduate internal medicine trainees. All were tested in their accuracy to detect a gallop sound. It is true that gallop sounds are notoriously difficult to correctly identify. So probably also the aim was pretty high. But what they found, so they asked all these persons to listen to some patients, and the gold standard that they used to compare with was a phonocardiogram, which shows you exactly the heart sounds. And this was used as a gold standard. So what they found was that the agreement between observers in identifying S4 or S3 was poor, and this was not a function of the experience of the observer. Okay, so you can see here the kappa coefficient is a way of trying to quantify the agreement between 2 observers in identifying in making a diagnosis, in this case, identifying a gallop sound. So we say that the accuracy is good when you have a kappa above 0.6. However, here, if you look, and you can see this is person by person. So these three are staff cardiologists, senior cardiologists. You see, the best one could get was close to 0.4, which is between poor and fair, but rather, so if you take here the average overall, it's about 0.3, which is rather poor. So this again makes the argument that it may be a problem in the technique itself, because these sounds are not so easy to get. There is a wide variability, and the diagnosis just made based on auscultation has some limitations. So what I want to show you here is it is important that we learn the skills. However, we cannot fully rely on them, because we know you need more to make the accurate diagnosis. But this is the initial one. So the initial one is important and also is the cheapest one. So you go in the room with just a stethoscope and with your own reasoning skills. Before ordering very expensive tests, you may think, well, there might be a gallop, maybe this patient has signs of heart failure, and then this may change your way of doing things. But however, in 2020, we need this sound clinical judgment, which cannot be replaced by any machine, but we also need technology. And technology may be a blessing if we use it properly. However, there is also a danger. And you know from many examples that any machine, any development can be used for the good or for the bad, can be used properly or improperly, can lead to progress or can represent a danger. Even if you take something as simple as this phone, this can be extremely useful because you can immediately search the Google for something or look into an app with the latest guidelines or search for a dose of a medication that you prescribe to your patient. But we also know it gives addiction, it leads to all sorts of issues and even to big dangers if you use these phones while driving and so on and so forth. So, of course, it's important the way we do this. Now I'm going to show you a case, and this is the case we have treated many years ago. We published this case in Circulation many years ago. It's a 46-year-old man who came for severe back pain. He was feeling this pain in the interscapular area, okay, so at the level of his posterior thorax. And he told us that his symptoms started about 2 months previously. He was a heavy smoker, but with no relevant personal or family history of cardiovascular disease. Now, when you examine the patient, he's telling you he has this pain on the posterior thorax, and then you look closely at the posterior thorax, and you also palpate, put your hand there, and you could feel there is a pulsatile mass at that very level next to his spine. And this is the thorax. This is a close picture of the thorax of the patient. This is the scapula, and this is the spine. And here where we made some dots, if you look carefully, you can even at the inspection, just by looking, see that this is pulsating, which is unusual, okay? And then you need to remember anatomy and to remember anatomical relationships. But what we did first, we did a chest X-ray, because this is the easiest imaging test to order. It's quite cheap and it provides a lot of information. about the heart and about the lungs. But you can see here, unusual are these two bulgings here. So we immediately realized that this may be a problem related to the aorta of the patient, because this seems to be large, and this is another bulging here, which we didn't know what it means. And then if you do echocardiography, obviously echo provides more information about the structures of the heart. This is a parasternal long axis view, and you can see here transthoracic echocardiography means that you place your transducer on the chest of the patient, and so the ultrasound beam will go through the cardiac tissues from anteriorly towards posteriorly. So the first structures that the ultrasound will see will be the most anteriorly located ones. The most anterior chamber of the heart is the right ventricle, and this is here. And the most posterior chamber of the heart is the left atrium. And this is the left ventricle, and the left ventricle communicates with the aorta through the valve. And here you can see that in diastole, there is a broad jet of aortic regurgitation leaking backwards from the aorta into the left ventricle. And this is the same sort of perspective from transesophageal examination. In this case, the transducer is in the esophagus, and the esophagus is posteriorly located, and it's next to the spine, and it's next to the left atrium. Why? Because I told you the left atrium is very posteriorly located. So this is the left atrium, this is the mitral valve, this is the left ventricle, this is the aorta, and this is aortic regurgitation. So the patient had severe aortic regurgitation, and then also by transesophageal echo, you see that the descending aorta, the thoracic descending aorta, is hugely enlarged, and it's also filled in large part by a layered thrombus. So all this is thrombus, and this is the circulated lumen. This is where blood flows. So this is an aortic aneurysm filled in large part with thrombus, and you can see this easily with echocardiography. If you then do a CT angiography, you can see here, this is the ascending aorta, and you see the upper part of the ascending aorta. There is another smaller aneurysm, which we did not see with echocardiography. And here you can confirm the big aneurysm that we have identified with echocardiography. And also this black part here is the thrombus, and this gray part here is the lumen that is circulated. And this is a 3D reconstruction of the CT, where you can see nicely the smaller ascending aortic aneurysm and the larger descending aortic aneurysm. But what is important here, this is a horizontal section through the thorax. This is anterior, this is posterior. Here is the spine, this is a vertebra here. And you see here that the aorta is so enlarged that it gets close to the skin, okay? And in fact, this is the part that you could feel pulsating when putting your hand on the posterior thorax of the patient. So this case shows you that, you start with the history taking. It is the pain, the patient explains where the pain is, and then you palpate, you have a suspicion there's a vascular structure because you had pulsations. What can it be at that level? It can be the aorta, and then you do some imaging from simple chest x-ray, to more complex echocardiography as CT and MR. This is an MR. And you have a full diagnosis and you know all the extent of the disease. So now we have a number of techniques that are helping us out. And you can see here that even with simple two-dimensional echocardiography, you can get a lot of information from one single site. So this is again parasternal long axis view, left atrium mitral valve, left ventricle aortic valve. Can anyone tell me what is wrong with this patient here? You can immediately tell me at least 3 diagnoses, or at least one. Anyone trying something?
The valve doesn't close.
Did you ever? Please, I didn't hear.
The valves do not close properly.
So the first thing that is striking, the valves do not open. You see this one here?
Mitral
Yes.
stenosis.
Now this you don't see very well because it's with color on it, but this is a valve that opens nicely. The patient did not have any problem with the mitral valve. Now we go to this one. Yes, this is severe mitral stenosis. It is barely opening, and there is a very thin inflow allowing the blood to enter the ventricle. What about the aortic valve? How do you feel about it? The same. You see, it doesn't open at all. So severe mitral stenosis, severe aortic stenosis. This is the left atrium, which is dilated. And what about this structure here? Any suggestion? So maybe I took you very strongly because you probably didn't see lots of echocardiography. I forgot to ask you if you had the chance to do some semio in the 3rd year. Where did you have the rotation?
We had it at Pantelimon.
Okay, I remember Miruna told me you worked with Dr. Nikita. So I guess you saw some patients there, or was it already closed because of pandemia?
We had the chance just for the first semester to see some patients because in the second semester the pandemic.
Okay. Okay, anyway, this is a big left atrium thrombus. Anyway, a cavity should look like this, like black and with no structures within. So when you see something that we call, this is an intracardiac mass. Okay, so it's a mass, it's something inside the heart. More specifically, this is a left atrial mass. And whenever you have severe mitral stenosis and you see a mass in the left atrium, there is a pretty high likelihood that that is a thrombus, because the mitral stenosis will limit the flow from the left atrium to the ventricle. There will be blood stagnation into the left atrium, and this will make the likelihood of thrombus formation pretty high. So the point I was trying to make is that even 2D echocardiography that is around for more than 30 years now can give you a lot of information. But also, more recently, we have advanced echocardiography. This is called speckle tracking echocardiography, and it is a technique that may allow us to assess in detail the function of the myocardium. So we can measure the way that the myocardium deforms, and this can provide us important information about left ventricular function in this case that can help the clinical decisions. Moreover, we have now easily available 3D echocardiography. And this is the 3D image of a mitral valve as we see it looking from above, from the left atrium towards the valve. This patient had a prolapse, which you can see here. This part is bulging into the left atrium. And this is a sort of a technique that, again, added on top of the others, can provide important information. So echocardiography remains in general the first-line imaging modality for many indications because it has some unique features. It is radiation-free, okay, so harmless. It is cost-effective, and you have often good image quality, and you can also rely on some more advanced technique if needed. However, there is one important feature in addition to that, and this is the mobility. There was a joke some years ago when a famous professor of cardiology was asked what is the most important part of the echo machine, and he said, definitely the wheels. And it's not entirely a joke, it's true, because the mobility of the echo machine can allow you to take it, to whenever place you need it, in the operating room, in the emergency room, and it is very useful in many of these instances, something you cannot do with CT or with MR, which are great techniques, but have several limitations, including the type of patients that you can assess. You cannot assess a critically ill patient who is on a ventilator to do an MR, but you can do an echo, and it can be life-saving or it can influence significantly your treatment. Moreover, not only the wheels, but now we have reached the dimension of a phone, and you have already probably seen this sort of echo devices that basically allow you to perform ultrasound exams everywhere, making it ideally suited for acute or severe patient. So we started with these huge machines that you will still see in our labs, that they may have 200 kilograms. And then we moved to portable sort of laptop, which you can take in your bag, and finally to something that you can take in your pocket when you go to the visit. All of that led to the expansion of users well outside the field of cardiology. So now we have a device which can be used by a family practitioner, by emergency doctor, by anyone, provided that they know how to use it. And again, it's a great thing to have it so available, but it comes with the danger that it will be used in a bad way. So we need to provide the education in order to do that. Lots of types of, we call them handheld ultrasound devices. We don't call them echocardiography machine, but it's an ultrasound device. Handheld speaks about the size of it, and there are lots of it. Some of them are directly related to the probe. The probe is linked to the device. In some of them, this can either be wireless, so you have a probe in your hand and you have a smartphone on the other, they communicate. Lots of things and lots of information that they can provide. And I'm going to show you some cases. So this is an image, this is an apical 4-chamber view, left ventricle, left atrium, right ventricle, right atrium, performed with a handheld ultrasound device. And this is the same patient looked at with a high-end, state-of-the-art echocardiography machine. Okay? So you can get information. However, this part of the ventricle you don't see well enough here, and you see better here. So of course there are some differences, and this is why you need to know what to expect from this device and the sort of use where you can safely use it. So first of all, it only has 2D and color Doppler. It does not have spectral Doppler, does not have M-mode, does not have an ECG attached to it, and obviously does not have advanced techniques. Secondly, quantification is limited. You can only do linear measurements. You cannot do complex measurements, volumes, and so on. And now a few things. The good news. The good news is that, first of all, of course, it's more accurate than the physical exam, which is not a surprise. But most importantly, and one student or one junior doctor could be taught to use this properly in a rather short duration of time. So, this is a study where some patients were examined by physical exam and by handheld ultrasound devices. And you can see here the percentage of cases where the physical exam was correct, percentage where the handheld was correct. And you can see that depending on the pathology, sometimes there were big differences. Okay, for example, valve disease, significantly better the handheld. LV function, abnormal LV function, significantly better the handheld device. Abnormal RV function. So when you talk about the function of the ventricle, when you talk about valve disease, significant valve, always the handheld ultrasound is better than the physical exam. However, pulmonary hypertension or mild valvular disease, they are similar. So this is why I meant you need to get trained and you need to know when to use it and what to expect. But this is true for any test. You need to know when to order a coronary angio. And the more complex, the more expensive, and the more risky the test, the higher the attention you need to pay to recommend such a test, okay? So if you limit this analysis to those who have moderate and severe valve disease, you can see that even there is a very important difference. Mitral regurgitation, tricuspid regurgitation, handheld were significantly better than physical exam. But if severe aortic stenosis is present or not, the physical exam did similarly well. So a patient who has severe aortic stenosis, you can do extremely well by physical exam alone, just to make the diagnosis. So again, even inside valve disease, where echo is really helpful, there are differences depending on the type of valve disease. And finally, this is the rate of correct diagnosis based on the initial echocardiogram. And again, you can see that, for example, chest pain or dyspnea, handheld was much better. But when we go to stroke, when we go to arrhythmias, differences are not really significant. And for this reason, we did, I was chairing the Association of Cardiovascular Imaging at the European level, and we've published last year a recommendation paper about how to use these handheld ultrasound devices. And basically, there are two big indications. One is in the clinical setting, and here again, you can split it based on out of hospital or in hospital, or as a screening tool for different cardiac pathologies. And the second big indication is as a teaching tool for students or for postgraduate junior doctors in their curricula. And then you need to think about the possible targets. And this is a large list. I'm not going to go into details, but that the point I'm trying to make is you need to know what you're looking for. You need to know when such a small device may really help, or when you cannot expect that it helps you. And also you need to know when to use it. And this is just a nice example I have from Professor Neskovic, who is an expert in focus ultrasound from Belgrade. So one night a fellow was on call, and he was called upon to see a patient, and he knew about this patient that he has an artificial valve implanted, and the patient came to the hospital because he had a syncope. So what did he do? He was an enthusiastic fellow, very excited to use this device, so he took the device and performed this echo. And these are two images that he got. This is a 4-chamber view, and this is a subcostal view. Here you can see the liver. And what he wrote in the file was, I think the patient has mildly reduced ejection fraction, but overall the valve looks okay to me. Now, the first thing to say about this is that on such quality of image, you can barely say anything. So the first thing, when you don't see well, you don't interpret. You say, well, I cannot say anything because I don't see much of it, okay? Of course, you can try to make some suppositions. Maybe there is something there, maybe not. But the problem is you need to not be overambitious, and you need to know when to stop. Because this is the same exam looked at in the following morning by the staff doctor in the echo lab on the state-of-the-art machine. And indeed, you see that the ventricle looks reasonably good. You see the valve. But what do you see? This is a huge left atrial mass occupying a large part of the left atrium. And you also see here, this seems to go into the valve, which has a limited opening. And then if you remember that this patient came with a syncope, things start to maybe fit around, and obviously it's a completely different story. So this is the fellow with the handheld, this is the expert with the full echo. It's quite different. Now, if you look backwards, you can see here that there was something, but you can only have a suspicion, and it's only here that you see it properly. Do you hear me now?
Yes.
Yes, we can hear you. We heard you the whole
Okay.
time.
Because I heard a sound, I wasn't sure if I got disconnected. If something happens, then just give me a call. Mirona has my number.
Yes, for sure.
Okay, so this is the wrong scenario to use such a device. This should not be used on this sort of patients, and this can lead to big problems because you can delay proper treatment or you can mistreat such patients. So there are things that cannot be done with such a device. You cannot quantify valve disease. You cannot speak much about diastolic function. You cannot speak much about pressures. You can get some qualitative gross data, but not much. So the appropriate use of such devices, and in general of new technology, depends on this triad: the scope, the limitations which you need to know, and extremely important, the human factor. But again, now I'm getting to tell you that you can be trained in using these devices, and I'm going to show you a couple of examples. This is a study, very interesting. You see, already 15 years ago, students were trained in using handheld devices for 18 hours training, 18 hours over 4 weeks, stage training. And they were tested, so students using handheld devices compared to senior cardiologists using the physical exam alone. And echocardiography was used as the comparator, as the gold standard. They looked at 61 patients who had significant heart disease, and you can see here, okay, medical students and medical doctors, you can see here that for a number of clinical settings, the students were better than the doctors. For example, left ventricular enlargement, left ventricular dysfunction, right ventricular enlargement was close to reaching statistical significance, but not on left ventricular hypertrophy, not on pulmonary hypertension. And then if you look at valvular lesions, again, students with the echo performed much better than doctors with the stethoscope and with the clinical skills regarding the sensitivity of the disease. And this is another notion that I would like to tell you a word about. Not sure if you remember what these mean. The sensitivity of a test means the ability of that test to rule in the disease. In other words, how often the patient who has the disease has the test positive. So a test which is very sensitive will detect most of the patients who have the disease. Specificity is the ability of the test to rule out disease. In other words, the percentage of cases of patients who do not have the disease in whom the test tells us that the patient does not have the disease, a negative test. So this is very important because you see here the sensitivity of the echo performed by students is much better than the ones with the doctors using the physical exam, but there is no difference in terms of specificity. That means when the patient has the disease, when you hear a specific murmur, then you know that the disease is there. So here you can see that finally, as this is another study, 5 students and 3 junior doctors, 2 hours tutorial, looking at 120 patients, again, history, physical exam, ECG, handheld devices, and then a consultant expert in echocardiography. And you can see here that the physical exam had a pretty low predictive value. This is positive predictive value, negative predictive value, for any moderate or severe valvular abnormality. Specificity was good, but sensitivity was poor. That means when the patient has aortic stenosis and I hear that murmur, the disease is there, but sometimes when the patient has severe tricuspid regurgitation, I cannot pick it up. So here you can see that the parameters, for all the parameters, for various echo, all the statistical parameters for various echo parameters were significantly improved when the students used the handheld devices. So you can see here that compared to the physical exam, where numbers were pretty low. When using the handheld devices, this got above 90% for all indications. So there is a fascination of the technology. The technology may be very useful indeed, but it cannot replace the human interaction. It cannot replace the history taking. Again, some diagnoses are entirely based on history. It needs the patient to build confidence in the treating physician. It is an essential human relationship. Empathy is crucial. It cannot be provided by a machine. Just holding your patient hand and sitting with him, it is something that is quite unique. And this pandemia is challenging us on all these aspects. And I will just finish with a couple of slides from some high-ranked journals exactly about the philosophy of it. So this is an editorial published in the New England Journal some years ago about point-of-care ultrasound and the role it may play in medical education. And they say, stop listening and look. Okay? A generation of physicians will need to be trained to view this technology as an extension of their senses, in the same way that many generations have viewed the stethoscope. But this development will require the medical community to embrace and incorporate this technology throughout the curriculum. And again, if you look just about some opinions across the history, this is Sir James Mackenzie, a very famous clinician, and what he told about the stethoscope many years ago. It not only for 100 years hampered the progress of knowledge of heart affection, but it had done more harm than good, in that many people had been forbidden to undertake duties for which they were competent and were subject to unnecessary treatment because of its finding. Somebody else said that the blood pressure cuff was felt to intervene between the patient and the doctor and to dehumanize the practice of medicine. And Samuel Levine said about the electrocardiogram in 1949 that greater the time spent in taking 3 ECG leads and then 9 and now 12, the less time is left to elicit an adequate history or to auscultate the heart properly. So again, any new technology faces some resistance initially, and it needs to be placed in the right context. Knowledge has to be built, and it needs to be used properly. And I will end up with this paper by 3 renowned experts. These 2 are the last 2 editors of one of the best imaging journals in the world, JACC Imaging. Braunwald is the patriarch of cardiology, the editor of the oldest cardiology textbook, and now he's over 90, but still speaks actively at conferences. So they together published this paper, Time to Add the 5th Pillar to the Bedside Physical Exam: Inspection, Palpation, Percussion, Auscultation, and Insonation. What they say is, while physical exam cannot and must not be replaced by technology, it can be enhanced by incorporating the right technology at the bedside. And that leads now to Professor Karp, because we also lack nowadays the brilliance of master clinicians. This is a rare occurrence now. And also, the other point is that now we also see early stages of the disease where even an expert cannot make a diagnosis, because the signs that we are taught are often signs of a late disease where you can really elicit those clinical diagnoses. And finally, it is meant to be used thoughtfully and selectively to answer specific questions at the bedside, and it is not meant to substitute the full echo studies if this is subsequently needed, exactly as I showed you in the example. So it does not need to replace the physical exam, for sure not the history taking. It does not need to replace the echo studies. It just needs to enhance our skills and diagnosis at the bedside. So basically, again, just think about the patient coming with an initial complaint, for example, chest pain. You perform an analytical process. You start with the hypothesis. You collect and interpret the data, come up with some hypothesis about the patient's diagnosis. You verify those hypotheses by searching for additional information, and then you take decisions about tests, treatment, triage, follow-up. And this is the person that is not so familiar. The person who has experience burns some of these steps and can immediately recognize the whole clinical picture at once. And so the process is that you need to understand all of these steps and develop the required expertise to apply this properly, and hopefully in future do this in a much shorter time. So to advance the art and science in clinical exam, basically the equipment that the clinician most needs to improve is himself. So that was it. With that, I thank for your attention. It was just more of a thought-provoking